I want now to move on into the really tough stuff. How do we actually measure health? How do we actually set about that? Well, there's an easy answer to this. The best measure is a life table, because death is a very definitive thing. And so provided you can record the death, and you can record some of the important details around it, then mortality is a self-defined thing, and that is the best measure. The ultimate measure of the health system is what is life expectation at birth. But much of the rest of health is highly subjective. All measures encounter problems. How do you define good? How do you define bad? And then once you've defined it, how do you actually measure it? Now, acute infectious diseases and disorders are relatively more straightforward. You go through a crisis, there's a cure, perhaps, or a death. Fine, that's easier. But then how do you measure underlying long-term chronic disorders that may in fact be life-threatening? For example, cancer that is in remission, as against short-term acute disorders that may not be life-threatening. For example, a hangover headache, which is the more important. And this is impossible, almost, for surveys on pathologies or on morbid events. There's the famous Hughes-McHugh survey, the World Health Organization survey of medical care utilization. And anecdotally, I don't know whether it's true or not, but it's a wonderful anecdote. They tested it in Alberta, and they found out a high proportion of Albertan men had problems which were sufficient to be hospitalized. And the reason for that was simple. It was the skiing season, and many of them coming down alpine skiing had hit trees and had to be hospitalized for broken limbs. But they were clearly not, by and large, in a life-threatening situation. Moreover, many measures must depend on self-reporting. Reporting primary healthcare contacts are very difficult, for example. Even if a prescription is given to the person who presents at the clinic, they go to the doctor and they expect to carry a piece of paper away with them, and they get their prescription. But really, are they sick or are they not sick? Is it life-threatening? Is it not life-threatening? Hospitalization may seem more easily, more simply identifiable. You're admitted into hospital or you're not. But that's not true. Many admissions are purely for observational purposes. In many cases, no cause of morbidity may be diagnosed. The person comes in, they're watched, and they're sent out and they say, sorry, we couldn't find anything. Or they may be affected by supply, by available beds as much as by demand. And demand may not depend on severity of need. For example, if you've got a section of a hospital which is private, they may get priority. And that happens in some countries. And there's, of course, competing demand and prioritization that I've mentioned already. Now, as I've said, death is self-defined. But what about causes of death and other contextual details? First of all, it requires somebody, as we do in developed countries, normally followed by notification. For example, that a death has occurred. There may even be rules on the books that, for example, if a taxi driver has the unfortunate situation of somebody dying in their taxi, they have to report that. Or owner of a building. Then there's formal registration in vital registers, and with that certification of cause, which hopefully is carried out by a medical practitioner. But even that is a problem, certification. Some deaths are not certified at all, or are not certified by a qualified practitioner. Typically, for example, coroner's inquests investigate these and most other what we call external causes, accidents, homicide, suicide, and so on. And then there's the difficulty of separating the immediate cause from underlying causes. And often these are subjective assessments. If followed by a post-mortem pathological examination, There may be a difference between what the practitioner has said by their observation and what the pathological examination shows. And today the certification systems on a World Health Organization, which is regulated by internationally, is becoming more and more complex with many more categories, and the lines between these may be rather fine. There's also the need to study the relationship between health and death. What are mortality, morbidity interrelations? So the major indices which we've developed recently attempt to combine these by measuring good or bad health for people who are still surviving. So the primary thing is you're still surviving. And are you surviving in good health relative to other people of your age, or bad health? Now these major methods are essentially life table methodologies. And they come away, they're actually called very often the Sullivan family, named after the demographer actuary who first of all developed these. And they ask, of those exposed to risk or of death or sickness, what proportion of the population succumb? And of those who are exposed to sickness, what proportion of them then go on and die? Now, some of these methods have become very widespread, and I want to just to run through these very quickly. I would hope you were able to follow these up. Now, in this, there are two different ways of doing it. First of all, there's a focus on pathologies or etiologies. The dailies, the burden of disease as it's known, and the qualies, both of which I'll discuss a little later, are based on that. Alternatively, there is functional health, which is the basis for what are called health expectancies. And I've already defined these. Can somebody perform the tasks of daily living at a level appropriate for their age? Or does some functional impairment inhibit this? You may have noticed that I wear glasses. Now, normally when we're looking at this, we just dismiss that, unless my eyes were so bad that the glasses could only partially help me, and that would impair clearly many aspects of daily living. But a prosthetic device such as glasses, by and large, aid you, and if you're wearing them, as those of you who have glasses know, you eventually forget that you're even wearing glasses. So, seemingly, the functional health methodologies avoid defining pathologies. But do they? What is a functional impairment? As I've said, is wearing glasses that? That said, methodologies do attempt, the methodologies for functional health do attempt to rate severity. All right, let's go through the different indices of health. First of all, what are called the dailies. Disability adjusted life years. These are very much at a macro area level. They're used by the World Bank. They were developed by two Antipodeans, Lopez and Murray, and they're also known as the burden of disease. The aim was, what does it cost a society, a population, an economy to pay for the diseases which are prevalent in their particular society? But it's theory-driven. Now, I could refer you to Wikipedia, which is quite good, but focuses mainly on the environmental causes. So, why are they theory-driven? Because, in fact, what is the attempt is made is to rate various diseases, and then you multiply essentially out to allow for the population factors, and this gives you an overall burden for the economy. Now, at the opposite end are qualies. These are essentially something at a micro level, quality adjusted life years. They're the micro analogue of dailies. Again, they're theory driven, and some people believe they're very useful for cost management, for prioritization, and for those things. They're very much favored by microeconomists in the health system. Now, apart from them are health expectancies, which are used by the World Health Organization, by Eurostat. Eurostat has very good data on this, and by major surveys across Europe. Elsewhere in the world, they're used right across Asia, for example. And these are measures of good or poor health while still surviving, but they are empirically driven. That is, they assess whether or not a person has some form of functional impairment and while they're still surviving. But they're not driven by theory, they're actually driven by determining this fact, although I must put that within inverted commas.